Hi, this is a video diary looking into my life leading a quality improvement project on ground in Burundi. And my project is to take all the things that we've learned from the global NGO sector, from governments, from different clinics, and make it into a playbook. Right now, I'm going to start working on the standard operating procedure for infection prevention and control. Basically, the steps we need to take to reduce healthcare-associated infections in the clinic, and the steps to maintain quality infection prevention standards. Okay, first step is writing down what I need to do. There's so many things to try to accomplish, so it's a little bit, overwhelming sometimes, where I'm like, oh my God, did I translate this document? Have I gone through this? Do I know all the steps here? Okay, great. So I've specified this a little bit more. I keep track of everything inside my reminders. I have a couple of different lists for this project, this list. Actually, I finished this, so that's pretty nice. And here, it's such a simple UI. Yeah, that's kind of about it. So this has to go. We have work to do. I'm working with a clinic that is at the primary stage level. There's 3 levels to healthcare. There's primary, secondary, and tertiary. And as you go up that chain, you have more specialized, more emergent services. My project is looking at this primary care center that wants to eventually be a world-class teaching hospital. And I'm looking at what they have, and I'm also looking at what reputable sources say they should have as a foundation. Specifically, I'm looking at the World Health Organization, the Joint Commission International, which is a global gold checkmark for healthcare. And then I'm using different data analysis tools from other sources like the CDC and the Tanzanian government, and using all of these things to create a recipe to establish quality, establish good feedback mechanisms, and good review practices. The project is really near and dear to my heart because a few years ago, I was in high school looking on this website called Our World in Data. On that website, there was a whole section dedicated to maternal mortality. And after seeing that data, I just felt like women were being so disrespected. So I kind of became dedicated and obsessed with maternal mortality. I would say the main reason is because the deaths are mostly preventable. 99% of deaths, maternal deaths, are preventable. I started focusing in on Nigeria, which has a ton of maternal death. And then I focused in on postpartum hemorrhaging, the #1 cause of maternal death worldwide. And then from there, I focused on uterotonics, specifically misoprostol, which is the low resource recommendation to stop postpartum hemorrhaging. The data back then was that it stopped 80 to 90% of severe bleeding. It was a very effective, low-cost intervention approved by the WHO list of essential medicines in a lot of Ministry of Health reports, but it still wasn't fully distributed. So for 2 years, I led a team. We worked with the government, we worked with local nonprofits to make a plan to distribute this drug. We started with misoprostol, but it eventually expanded to also look at things like HIV in antenatal care and looking at data collection in rural environments using things like the DHIS2. All of that was very cool, self-created public health experience, and it was amazing. Fast forward, I have this grant in my university scholarship. I knew I wanted to go back to preventing preventable deaths. Such an obvious thing to do. So I got connected through a series of warm intros to a super cool organization, Madiro. And basically, we settled on me actually coming to Burundi and working on a quality improvement project, coming up with a holistic toolkit for establishing and expanding the quality of the clinic. It's been a lot of reading, like thousands of pages of reading. The World Health Organization specifically has this huge database on quality improvement. There are a lot of skills that I'm using and leveraging. First and foremost, organization. There's so much information that I'm taking in, but being organized is the biggest asset. And second to that is being insight driven. There's a lot that I can read. There's a lot of fancy policymakers that have set forth these rules, but A, everything's not applicable. And B, even if everything is applicable, you have to prioritize. So considering the so what, the World Health Organization recommends the ABCDE method as the first response to emergency. What does that mean for our clinic? Taking something like that and saying, okay, well, the most important thing is that these vitals are checked, and they're checked every time there's considerable decline in the condition. There's a whole document on specific scenarios and what to do and how to manage them and looking at the symptoms. But what matters is doing the 80-20. So there's no point in printing out the 85-page document that talks about acute respiratory infections if we will just have to transfer them all of the time. What we care about, the implication, is the symptoms that are most likely to direct to this, and then how to transfer them. And we have to be able to map the high priority present versus the high priority future. So there's always something, whether you're in Canada or Burundi, there's always something a health clinic can do better. That's why it's so important to establish a quality improvement system, a way for people to meet on a routine basis to specifically discuss what to implement. Really, the asset I'm trying to provide is a critical contextual lens on taking these standards and mapping them out into something that's feasible. It's been such a cool journey just to see these amazing health workers in action, to see a clinic that is truly saving lives. Before 2019, when the clinic was established, there was no healthcare in the region. People had to travel 70 kilometers to go to the nearest facility. That is hard, that is expensive, especially for people who don't have any vehicles. And along the way, I have learned so much. While I've really appreciated the wealth of knowledge that the World Health Organization has, I've really learned to internalize that they are not good for implementation. First and foremost, they are way too long. No one who is working in a constrained, low-resource environment has time to read a 73-page document on hand hygiene. Second of all, language is so inconsiderate. So much of the world's poorest countries don't speak English as their primary language, and yet most of the implementation toolkits are in English. These documents are really great for policies, especially in the Western world. They depict the Cinderella scenario. What to do when there's unlimited resources, unlimited energy, unlimited water, unlimited staff, unlimited willpower. Here's what you do. Well, what if the clinic doesn't have access to steady electricity? Or what if the clinic doesn't have refrigeration and we can't store oxytocin? What do we do? That's not included. Even for things like severe malaria, tuberculosis. These diseases disproportionately affect low resource areas. They're all for these idealized states, assuming so many resources and so much willpower that frankly would be really hard to bring down to many clinics around the world. They have time to write 766 pages on community engagement materials. Here's how you go out into the community. Here's how you hold these conversations. Here's who you should care about, the stakeholders. But when it comes to providing the resources to reduce the burden to go out and do these things, that's on page 767, apparently. It is really hard to take what exists in Cinderella Land and implement it in a place that is just not like that. So I'm so grateful to have gotten this exposure and to really feel the friction of going from theory to reality. Thanks so much for hearing me out. If you're interested, I wrote this article called What I Would Do If I Ran the World Health Organization. I think I had some kind of fun, interesting ideas in there. Otherwise, it'll be on to the next video diary.